Dr. Ankush Chaudhary. Dr. Ankush Chaudhary is a senior pulmonologist of Delhi. He is the director of Lung Sukh Hospital, Delhi. Dr. Ankush is having rich experience in pulmonology segment. I request him and I handing over the session to Dr. Ankush. Yes, sir. Over to you.
Thank you so much, Vivekji. Thank you so much for the warm welcome. And I must thank all the participants, those who have spared their valuable time for on a Sunday evening. So, and I'll make sure that we'll make it very crisp and very practically useful for all of you. Today, we shall be discussing about challenges in chronic cough management. So, as we told that discussion topic for today shall be challenges in chronic cough management and how should we approach it in the current scenario. First of all, very important thing that cough is not only a symptom of a disease, of an underlying disease, but it's a very important vital protective reflex. Because as you all know that it is an indication from the body that something is wrong in some part of the body. Also, it will prevent the aspiration from the vocal cords down into the trachea, thus enhancing the airway clearance. Very importantly, that excess amount of cough, which we'll be discussing, what is chronic cough, if it lasts for more than 8 weeks. What we have seen in our OPD practice is approximately 5 to 10% of the patients approaching us have got this symptom. And at times the cough is so much in severity that it debilitates the patient's quality of life, as well as it will start hampering other important factors in life, such as it might cause urinary incontinence. Certain people, they even report cough syncope, and because of chronic cough, vocal cord hoarseness develop, and they even develop dysphonia. So as I told, that chronic cough is something which lasts for more than 8 weeks in duration, and it is not being cured by the routine treatment which is being usually prescribed. Also, these patients give us a history that they have visited multiple doctors and still there is no resolution of cough. So there is something underlying which is being missed either on history or an examination, or we have not been able to detect the right cause of cough. So today we'll be focusing on that, what are the various causes of cough, and many a times they are being missed in routine diagnosis. So some of the very common causes of chronic cough, and these are not the only causes. In fact, there can be significant other number of causes as well. We'll try to cover as many of them as possible. Gastroesophageal reflux disease. I'm starting over here. This one, gastroesophageal reflux disease. This is one of the most important and underdiagnosed causes of cough. Approximately 25 to 30% of the patients, those who come to us with cough, if they do not have asthma, if they do not have this entity, asthma, then many a times they are just being managed with proton pump inhibitors or antacids with certain dietary changes, lifestyle modifications. The cause of cough in such patients turns out to be gastroesophageal reflux disease. So always remember that one should always ask history for gastroesophageal reflux disease. Then I'm moving anti-clockwise here. Asthma in pulmonary practice with general physicians or my internal medicine friends, it is a very common diagnosis. And majority of you are managing it nicely. So today's discussion, we won't be focusing much on asthma. We'll be focusing on other causes of chronic cough. Coming to similar variety, which presents the presentation, clinical presentation is almost similar, like asthma, is eosinophilic bronchitis. In eosinophilic bronchitis, these patients on examination, they usually give history just like asthma. However, on their clinical workup, we find that the blood levels of eosinophils are significantly higher. So eosinophilia is the one which is causing the cough. Another important entity which is very frequently missed is post-infectious. Now, what do I mean by post-infectious? That there is a history of a respiratory infection in the past. It could be acute, like it could be like 7 days ago, or it could be even 7 years ago. So when there is a long-standing history, then it gives rise to something called as obliterative bronchiolitis. That we termed as post-infectious obliterative bronchiolitis. It presents as an obstructive airway disease. For that, management is required. Slightly different management from asthma, but it's a very, very important cause. Similarly, post-infectious bronchitis can also develop, which is usually acute in onset. And usually the patients will be giving this history of upper respiratory tract infection. And post upper respiratory tract infection, once the symptom of upper respiratory tract URTI are resolved, they develop post-infectious bronchitis, which again requires management. Then environmental factor, very, very important. And frequently this is missed. So over here, I'll share very common example I often share with my patients also, with my under trainees also. We were treating a family for cough, and we could come to the conclusion of a diagnosis of interstitial lung disease. Interstitial lung disease is also a very, very common cause of chronic cough, which is often missed. However, the cause for interstitial lung disease in this group of patients was something in their environment. Actually, in their home, they had a blocked chimney, which was not allowing the gases and the fumes to go out, which led to chronic accumulation of the coal and the tar in the chimney, which led to development of interstitial lung disease. So environmental factor is very, very important. Many patients come to us, those who are school teachers, and they are using chalk. And while they are writing over the board, it causes certain release of the microparticles from the chalk, which triggers the cough. Similarly, there can be like exposure to dust during the environmental or occupational history is there. So these environmental factors, looking at environment is very, very important. Similarly, environmental factor plays a very important role in children, because usually children are playing with soft toys or stuffed toys or pets, or even pets are there at home. Unless and until these triggers are removed, the cough management gets difficult. Then all of us are aware about pulmonary tuberculosis, so I'll not be going into it. The medicine-induced cough, ACE inhibitor. ACE inhibitor is one of the drugs like commonly used. You people have been seeing Ramipril. Always in your history, when there is a chronic cough, whenever you are dealing with chronic cough, always ask for the history of whether you are taking any medicine which can predispose to cough. Then upper airway cough syndrome. Upper airway cough syndrome is nothing but it's a new terminology for post-nasal drip. In chronic rhinosinusitis patients, there is a post-nasal drip. So that is being termed as upper airway cough syndrome. Then upper respiratory tract infection, then cardiac origin. Cardiac origin, like there could be any mitral stenosis is there, or there could be suppressed ejection fraction is there. So these kind of things, or pericardial effusion, tamponade, many things in the cardiac origin can give rise to cough. So these are the common causes of chronic cough, and purposely I have not written interstitial lung disease over here. The reason being that interstitial lung disease requires significantly different kind of management. The approach to treatment is also totally different. You people can remember interstitial lung disease is one of the causes of chronic cough, but because the management diagnostic principles are totally different, so we won't be discussing that today. Now, mechanisms of cough. Almost everything we have discussed till now. Some people even term this as cough hypersensitivity. Usually hypersensitivity we term as when the airways are in a position of when the airways are hyper responsive to any particular allergen or any particular environmental factor, or they are hypersensitive to gastric reflux, or there could be because of temperature variation. And the patients usually report this hypersensitivity as something called as itchy in the throat. And this is a very common complaint with the patients. You people must have experienced. They say that, sir, गले में कुछ फंसा हुआ लगता है, ऐसे लगता है कि गले में कुछ छिल रहा है, or there's a chronic throat irritation, unpleasantness, and even they demonstrate like recurrent throat clearing. So these are the common presentation. This is how a patient comes to us. This could be triggered by changes in temperature, environment, perfumes, aerosols, strong smell. What is actually happening is this is a normal looking airway. Okay, so when this is a normal looking airway, it has got the lining of the airway, the mucosa is just like our skin. What happens in cough hypersensitivity or chronic cough is because of the chronic coughing, it's severely spasmodic or under bronchospasm at times, But the most important factor is inflammation. The chronic inflammation which is ongoing in the airways, this is what usually is causing the chronic cough. So one need to target this. And uh, so this is what we need to be very, very cautious, that all these diagnoses should be very, very clear in our mind when we are dealing with a patient of chronic cough. And alarms should be on, that whenever a patient comes saying that my cough is not getting resolved, even after multiple weeks. So the very first diagnosis in chronic cough is tuberculosis. In Indian scenario, tuberculosis should always be searched for. Then there are certain red flag signs for chronic cough. What do I mean by red flag signs? Because if these signs are present in your history, then it's really alarming. Why? We'll just look into. So hemoptysis, we all know that hemoptysis could be life threatening. That's why it's a red flag sign. It could be mild at present when the patient presents to you, but you never know when it could be converting into a massive hemoptysis or life threatening hemoptysis. So always be very, very cautious while managing patients of hemoptysis. Now, the next 2 points are about smokers. Whenever there is a significant smoking history, it always predisposes the patient, we know that, to the increased risk for lung cancer. Okay, so it's also a red flag sign. Prominent dyspnea, especially at rest or night. What does this indicate? That either it is a uncontrolled asthma in the background, or there could be a cardiac etiology. So this is also a red flag, because cardiac patients usually, if they are involved, they might not give us much time. Substantial sputum production. What do I mean by substantial sputum production? Although they have written that more than 1 tablespoon per day, but copious amount of expectoration, what we consider in clinical practice, is 1 cup full of sputum, a 250 ml cup, more than that in 1 full day. What does this indicate? This indicates that the patient has got underlying bronchiectasis. The bronchi are dilated. So there is a chronic infection which is ongoing, which has led to the dilatation of bronchi. So substantial sputum production is possible only if there is bronchiectasis, or there could be possibility of lung abscess, or there could be possibility of underlying lung cancer as well. So these are the common conditions in which there is a substantial sputum production. Voice hoarseness. Voice hoarseness, again, it is a pointer towards possibility of underlying lung cancer. Systemic symptoms, fever, weight loss, could be present with tuberculosis, could be present with interstitial lung diseases, it could be present with autoimmune pathologies, it could be present with lung cancer. Then gastroesophageal reflux disease, we have already discussed. Certain cases may have GI bleeding because of the hematemesis or melena, that could be pointer towards certain underlying GI diseases. And then there could be recurrent pneumonias. So recurrent pneumonias can also cause recurrent cough or chronic cough, and the cause for recurrent pneumonias is an extensively we have to evaluate what is causing this patient to have recurrent pneumonias. Either it could be having uncontrolled sugars, or uncontrolled diabetes is there, or this patient is a chronic smoker, or this patient is on oral steroids or inhaled corticosteroid for a significantly prolonged time, for a prolonged time. Or there could be foreign body might not allow the lung which is distal to the foreign body to expand, and it might cause recurrent pneumonia. So there are significant number of causes for recurrent pneumonia. Then we come to what are the challenges what we are facing. So as far as I am concerned, I don't consider this as a challenge if we counsel our patients properly, that see, this is your condition, what we are suspecting, and you have been going through this condition for so long, like 2-3 months you have been going through. So we need to come to appropriate diagnosis and then start treating it. Definitely all the patients, majority of our patients, they get relief. So if you go step by step as we are discussing, you also will be able to treat it very, very easily. Okay, so but where does the challenge come? The challenge comes that 50% of the patients, when they approach us, 50% of the patients are being labeled with wrong diagnosis, and they are on the wrong treatment. Okay, and more importantly, if 10 patients are coming to me with whatever treatment they have been prescribed for cough, approximately 30 to 40% of them, they do not report any significant relief in their symptoms. Why? because they were not being adequately diagnosed. They were not being adequately questioned about the history, about the symptoms. Okay, so this is very, very important. Another important challenge in chronic cough is that with chronic cough, the more the amount of cough continues, more it will predispose your patient to the risk of developing syncope, arrhythmias. Also, they could be developing severe malaise, or there could be body cramps. Even to the extent that the old patients or COPD patients, they even can have fractures, rib fractures. And uh, something very, very socially debilitating is urinary incontinence. So all needs to be kept in mind, and one should approach the diagnosis like we are discussing. Now coming to the management. So we have already discussed about what all things you will be considering, like checking for warning signs, drugs intake history, environmental or occupational history is important, asthma or a variant of cough variant asthma, eosinophilic bronchitis. We have discussed all these causes. Another very, very important cause of chronic cough, which is missed in history, is obstructive sleep apnea. What is obstructive sleep apnea? Is that because of snoring, because of the because of the collapsibility of airway, patient undergoes something called as sleep fragmentation. In simple words, that because the patient is snoring, the airways get collapsed at night when the patient is sleeping, which leads to transient episode of hypoxia, which we call as apnea. And there is a very that the patient arises from the sleep for very, very split seconds. And the usual presentation is like they will snore and the intensity of snoring will go up. Then there will be brief pause in which the patient rises up like this and then goes back to sleep again. This pattern of snoring and apnea is being observed only by someone who is sleeping adjacent to the patient. Patient usually are not aware of this history. So one need to be very, very careful and meticulous while taking the history. Also, the patients of sleep apnea, usually they are obese, not necessarily. There could be a normal weight as well. Also, they give very, very important histories like early morning headache is there, mood irritability is there, frequent daytime sleepiness, excessive daytime sleepiness is there, or memory lapse is there, uncontrolled diabetes, uncontrolled BP, obesity. So all these kind of pointers, they go towards sleep apnea. This is also very, very important. Then another common cause of chronic cough, whenever any patient comes to me with any kind of respiratory complaint, I usually tell them, and I also divide the complaints in my head for my ease of understanding into only two broad categories. One is that it is pathological, means there is some disease underlying. Second is when there is no pathology identified, then it could be psychosomatic or it could be somatic. Okay, so these are the only two causes. So before referring them for counseling sessions, before referring them for psychiatric assessment, I always prefer that one should rule out pathology. So either there is a pathology or there is a somatic. So somatic cough syndrome. Fine. So we have already discussed all this, that whatever is the history, whatever is the diagnosis we are thinking about, we need to manage it accordingly. A very, very important message, like the fourth pointer which I have written, refer to a cardiologist if required. Please don't be hesitant in your practice to refer whatever patients you consider that if the cough is like not getting cured, if the cough is not getting diagnosed appropriately, please do not hesitate in referring them to your colleagues or referring them to a pulmonologist or refer to a cardiologist is needed, because at the end we all consider only one thing which is important, that is the benefit of our patient. Okay. Also, the drug intake history is very, very important. We have already discussed it. This is the same thing, just in a flowchart form, that what all things we should be considering in our history. That's why I'm paying significant amount of time to history taking, because history taking is what will lead to your diagnosis. History taking is what will make the diagnosis very, very clear in your head. Okay, so red flag signs, history of occupational exposure, travel exposure, ACE inhibitor, or certain patients are there on gliptins, then we need to discontinue these medicines. Also, then very, very, very important causes which we have already discussed: upper airway cough syndrome or postnasal drip. Asthma, we need to evaluate with spirometry or any other kind of bronchoprovocation challenges. Non-asthmatic eosinophilic bronchitis or gastroesophageal reflux disease. Usually, the treatment which is required for upper airway cough syndrome is either anti-allergics or decongestants. Might even require a very, very short duration course of antibiotics if you feel that sinusitis is involved. Then asthma, inhaled corticosteroids with bronchodilators are usually the treatment modality of choice. With non-allergic eosinophilic bronchitis, eosinophilia needs to be treated. Also, avoid the trigger which is causing this. Then inhaled corticosteroids could also be used. With gastroesophageal reflux disease, already we have discussed that proton pump inhibitors along with antacids, along with lifestyle modification is what is usually needed. In most of the cases in my clinical practice, which we have observed, that 2 to 4 weeks of treatment is usually sufficient to come to a conclusion that whether the diagnosis which we are working with or the treatment which we are giving is appropriate or not, whether we are on the right track or not. Okay. If there is an inadequate response, then we should go further with the evaluation. That one should be very, very cautious now. If still it's not controlled, whether we are dealing with an interstitial lung disease or not, or there could be an uncontrolled asthma or not, or there could be other possible causes which could be picked up in high resolution computerized tomography or not, or we are dealing with tuberculosis or not, for which sputum examination or recurrent pneumonias workup. So all those things are usually required. And all those red flag signs we have already discussed. All right. So these are the very same signs: hemoptysis, smoking history, which could predispose to lung cancer, dyspnea at night, especially, which would be pointed towards cardiac disease, hoarseness, again towards lung cancer, systemic symptoms for your tuberculosis or lung cancer, like fever, weight loss. Okay. Certain patients complaining of trouble swallowing when eating or drinking, again going towards cancer etiology, vomiting, recurrent pneumonias. All this we have already discussed. We'll be coming to your questions in a while. Just first, when I am completely done with the history, I am repeating all the points again and again. Majority of the flowcharts are showing the very same things again and again in different forms. Once we are done with the history, before coming to the treatment part, we'll take a few questions, or we can take the questions at the end also. It won't take much of time now. All right. So now coming to assessment of cough in adults and children. Children also will be doing. This is again very, very same thing: history, physical examination. What is the total duration of cough? Is there any smoking history, any family history or not? Visual analog scale one can go through, but usually we do not do it in the clinical practice because of the lack of time. Then there are other systemic symptoms associated for the throat, chest, or GIT. Is there any drug history which is there? Sleep apnea history is there or not? So all those things, very, very same things which we are discussing. Then what is the level of blood eosinophils? What's the status of chest X-ray? These are very, very important things to be considered. All right. Then additional evaluation, which could be later needed. Again, same thing. After 4 weeks or 2 to 4 weeks, when we have already given appropriate treatment, still the patient is not responding, one might need a high resolution computerized tomography. Then sputum for eosinophilia might be needed. Sputum for tubercular workup might be needed, like AFB, gene expert, or AFB culture. Then bronchoprovocation testing is usually not needed, but might be needed in certain cases. Then also in certain cases of asthma, I like to mention through this podium that if one is encountering a case of difficult asthma or difficult to control asthma, few points to be kept in mind: whether you have controlled gastroesophageal reflux disease or not, whether you have addressed the issue of chronic rhinosinusitis or not, whether you have removed all the environmental factors or not. These are some of the common causes which does not allow your asthma to be controlled properly. Then whether the technique of inhaled therapy, whichever you have prescribed to the patient, whether the patient is taking it adequately, whether the patient's technique is adequate or not. Trust me, more than 50% of the patients coming to us in our OPD, whenever they are being prescribed by some other of my colleague, they are not taking the inhalers properly. And when we rectify the technique of inhaler, majority of the times the symptoms goes away. So inhaler technique is also very, very important. Then appropriate doses of the inhaled therapy has been used or not, whether there is an eosinophilia or not, which has been tackled or not. If all these factors have been checked, okay, you prepare a checklist that all these factors are right, still your asthma is not getting controlled and your diagnosis of asthma is sure, your diagnosis is correct, then many a times what you are dealing with is allergic bronchopulmonary aspergillosis. Always search for allergic bronchopulmonary aspergillosis in patients of uncontrolled asthma. Okay, so this is also very, very important. Now, the other things which are written that consider gabapentin, pregabalin, pro-motility agents, these are for the ones which are not getting controlled, and when we label them as neurogenic cough or somatic cough, these might get controlled with gabapentin, or low dose opiate like morphine could be given, or pro-motility agent, just to be on the more safer side for gastroesophageal reflux disease, because it decreases the severity of GERD. All right. Now, in children also very, very same kind of workup is what is usually needed. Detailed history, physical examination, presentation of cough, and performing a spirometry like we do for asthma patients. So whether it is a wet cough or dry cough, in wet cough, we know that we send for sputum cultures for not only your gram stain and cultures to look for underlying pneumonia, but for also tuberculosis. Okay. So almost the very same kind of workup. And if there's a dry cough, then as told in the history taking part, that for children, one need to be very sure about the environment in which they are living, whether their bed sheets are being thoroughly cleaned or not, whether they have any pet in their environment or not, or there are some kind of stuffed toys or soft toys which they are routinely playing with or not, whether they are using any kind of material which contains fur. Okay, so these are very, very important for children. These are what are irritants. These are which are causing the recurrent allergies in children. All right, and then also important is lifestyle modification, because we need to boost their immune system towards the allergies, towards the environment. All right, and then again, inhaled corticosteroids or bronchodilators might be needed as per the spirometric assessment. This is a stepwise approach for chronic cough. History we have already taken, and whatever we are thinking, it could be smoking induced, it could be ACE inhibitor, cardiorespiratory status. Then first step in a outpatient basis, what one can do is a spirometry with a bronchodilator reversibility testing. A bronchodilator reversibility testing is always a must to conclude a diagnosis of asthma, because there should be a bronchodilator reversibility of 200 ml and 12% in FEV1, so as to confirm the diagnosis of asthma. A chest X-ray is usually needed so that we can assess whether there's any lymph node or not, which is pressing upon the airway, or there could be a pneumonic patch, or there could be a pleural effusion which is causing this chronic cough. So X-ray also helps us in significant assessment, or there could be a lung mass also which would be seen on X-ray. Complete blood count again is a pointer towards whether the patient is having any eosinophilia or not. And referral, like for the red flag signs, we have already discussed whether there's a significant weight loss, hemopsis, fever, abnormal chest X-ray. Okay. Step 2 management is when asthma. We all know that for asthma, the gold standard treatment is inhaled corticosteroids with long-acting beta-2 agonist. Inhaled corticosteroids are the ones which are the gold standard treatment for asthma, because as I already showed you this model, the inflammation is the part which we need to take care of, and the best anti-inflammatory agent is the inhaled corticosteroids. Other agents might be like add-on. While in COPD patients, although bronchospasm is ongoing, although chronic inflammation is ongoing, but they need to be very on a very tailored regime. At present, what we have seen, majority of patients, those who are being referred to us, they are on the very same treatment, whether they are asthma patients or COPD patients. They are on ICS/LABA, inhaled corticosteroids and long-acting beta-2 agonists. While that is not the right approach for COPD patients. LAMA, long-acting muscarinic antagonist and long-acting beta-2 agonist. These are the two, LAMA plus LABA. These are the ones which are preferred. While inhaled corticosteroid, they could be added as the severity of COPD increases. Okay, but 50% of your COPD patients will be managed well, and in fact, adequate control is achieved with LAMA and LABA. Smoking cessation is always of paramount importance. Changing the drug if the drug history is there. As far as chronic rhinosinusitis is concerned, antihistamines, certain nasal medicines, anticholinergics, decongestants are usually needed, and GERD we have already discussed. Now, if still the cough is persisting, then what could be done is that treat as per your confirmed diagnosis. You go in for further evaluation. Also, when one is going into further evaluation, few things are very, very important. Whether your previous diagnosis was correct or not, whether the patient is taking the adequate amount of medicine or not, whether the technique of the patient is correct or not. Because these are the usual fallacies, these are the usual pointers which will help you whether we need to evaluate it aggressively or not. All right. Then, if still prior to step number 4 or prior to this, if cough persists, what I would advise you all, if still the patient is having problem, if still the patient's symptoms are not controlled, then always consider interstitial lung disease, ILDs. Because even if after inhalers, even if after your adequate amount of ICS, LABA, LAMA, all the drug history, antacids is being given, antihistamines are being given, a short course of oral steroids, even if severe asthma is there, then always look for interstitial lung disease. And how to diagnose interstitial lung disease? Two important pointers in spirometry. When you are doing a spirometry test, it will be having a restrictive lung pathology, restrictive lung disease. That is the ratio of FEV1 by FVC would be more than 70%. Okay, that is an interstitial lung disease pointer that ILD patients usually have a restrictive lung disease, while asthma and COPD patients have an obstructive lung disease. This is very common. You all must be knowing it. Also, high resolution computerized tomography will help you identify the pattern of ILD. While a chest X-ray, a normal routine chest X-ray is sufficient to pick up the reticulonodular infiltrates. जाल के जैसा दिखेगा आप लोगों को chest X-ray के अंदर. So that is sufficient enough for a patient to be diagnosed as interstitial lung disease on a high resolution computerized tomography. HRCT will help you identify the various patterns of ILD. Okay. Then if it's still not ILD, then always as I have already told, that consider the diagnosis of ABPA as well. Rule out ABPA. It could be allergic bronchopulmonary aspergillosis. If these are also ruled out, you have ruled out a cardiac etiology, you have ruled out whatever we have discussed, then there could be issues with the voice, vocal cord issues. Okay, then there could be issues with the neurogenic cough or psychosomatic cough. All right, so these are the things which needs to be considered. So like we have already discussed what we have written over here, gabapentin, pregabalin, morphine, amitriptyline, these all will be helping in your neurogenic cough. So this is called as the neuromodulatory trial. And speech pathology is usually what happens is the patients, those who have a history of long-standing cough, not resolving with all the treatment, whenever they are given speech rest, whenever they are given speech pathology, whenever they are given voice training, that is when they start improving. What is this etiology? This is because of chronic use of the vocal cord. These are usually seen in singers. They are usually seen with teachers, those who have a history of long-term vocal cord abuse. Okay, so needs to be kept in mind. Then again, obstructive sleep apnea also needs to be kept in mind. Coming to anti-cough agents, there are certain cough center suppressants. All of us are using them: codeine, flucodeine, dextromethorphan, antihistamines. Two of the agents which are of significant importance, which all of us must remember as they give excellent clinical results: benzontate and the levocloresatine. So we'll be discussing this. Levocloresatine is available in usually syrup forms. There are a few formulations which are available. And benzontate, this is an age-old molecule, used to come earlier from, if I remember correctly, from 1960s to 1980s. Probably it was significantly available, then was withdrawn from the market because of certain reason. Now again, since the past 2 to 3 years, it is again available. And this is a wonderful agent, benzontate, as we have observed in chronic refractory cough. If your diagnosis is right and still the patient is suffering from cough, this helps us achieve significant cough control in more than, I would say, 50% patients. Okay. Certain pharyngeal like soothing agents, lozenges, lintus are available. Then expectorants, they are usually helpful if there is underlying sputum collection which the patient is not able to expectorate out because of either sticky secretions, so or poor cough reflex. Then expectorants could also be useful. Again, mucolytics will be helpful in the conditions where there is a thick secretion. Okay, in thick secretions, one needs to like liquefy the mucus. So bromhexin, acetylcysteine, ambroxol, these are the agents which are available. Coming to benzontate. So benzontate, as I have discussed, that is a wonderful molecule, helps us achieve significant amount of cough control in more than 50% of refractory cough patients, especially useful in the cases in interstitial lung disease. So interstitial lung disease, unfortunately, we have got limited amount of management available with steroids, antifibrotics, immunomodulators. Still, the patients usually, they are complaining of cough. In such patients also, in more than 50%, it is helping us control the cough. Also, chronic cough syndromes, chronic asthma patients, it is helping us significantly. It's a peripherally acting molecule and does not have a central acting narcotic effect. So does not has the side effects of the molecules like gabapentin or pregabalin or amitriptyline, because they might cause sedation. But this is devoid of any sedative activity. Sorry. And the onset of action is quite good. I'm not sure 15 to 20 minutes, but what we have usually seen is approximately 30 minutes to 1 hour. Clinically, what we have observed, patients start reporting certain benefits. Okay, so this is significantly good. This is available in capsule forms in 100 mg, if I remember clearly, usually in the doses of 3 times a day, and can be given from 300 to 900 also. Okay, so significant amount of broad range is available to us. Let's see this study which was done on benzontate capsules. 100 mg TID was given for chronic asthmatic bronchitis, and significant improvement in the symptoms they report. Like you see, the excellent control of symptoms over here is in more than 56% of the patient. Like I am also telling in my clinical practice, more than 50% of patients, they report that significant relief in the symptoms. And the relief which I am telling is what I have observed is not in this dose of 100 mg TID, but in 600 mg. So what we advise is 100 mg, two capsules or 2 tablets 3 times a day. So at 600 mg, I have observed this significant benefit. This is the this percentage. Although this study is quite old, 1957. As I told that this molecule was earlier available in 1960s. So this is the same. These are probably the same studies, but the very same results we are getting. It's also being head-on compared with other molecules like ephedrine, ammonium chloride. So on addition of benzontate, there is a significant improvement. There is a significant improvement as we see. Like see over here that the control mixture, it's 67%. When mixed with benzontate, it's improving to 71%. Severity lessened. Okay, in all the groups, we see that effect on sputum also they are mentioning, but this is something which is controversial. I personally do not see any effect on sputum, but definitely the control of cough is significantly better. All right. Now, chronic cough in TB patients. Before going into benzontate in chronic cough in TB patients, one should be very careful in examining and diagnosing what is causing this chronic cough in TB patients. A few pointers. First of all, TB, when it affects the airways, it can cause something called as obliterative bronchiolitis. Like in the very starting, we discussed about post-infective obliterative bronchiolitis. So tuberculosis can cause post-infective obliterative bronchiolitis, for which the management of choice will be again inhaled therapy in the form of lama-laba, and at times one can add inhaled corticosteroids or oral bronchodilators also. Okay. The second thing is, it is a rare side effect, but in our clinical practice we have observed that rifampicin as a molecule itself can trigger asthma in patients. There are a subset of our patients, those when they were started on tuberculosis treatment, their episodes of bronchospasm, wheezing episodes, they increased. And because rifampicin is a very, very important molecule in the anti-TB therapy, we cannot withdraw it, but with a good amount of inhaled therapy, it can be significantly controlled. If it's still not getting controlled, then definitely one can go with oral benzontate in these patients also. Many a times there could be chronic cough in TB patients because of either pleural effusion or there could be pleural thickening as well. So that's a different scenario. One needs to tackle that differently. Okay. Now coming to the other molecule, the cough suppressant levocloresatine. Levocloresatine, this is available usually in the syrup form, and it blocks the cough receptors which are present in the brain, which are known to cause cough. And usually the cough syrups and the difference between the benzontate, the difference between the two molecules, that benzontate, we are using it for significantly longer duration of time. In our clinical practice, we have even used it for 1 month to 3 months, or even 6 months without any side effects. While the cough suppressants or the cough syrups which we are using, they are usually given for a short duration of time from 5 days to 14 days. I usually do not prefer giving them for longer duration. Okay. So now coming to, this is one study for safety of levocloresatine in dry cough. 100 patients were observed, enrolled in the study, and it was found to be significantly safer and significant reduction in the severity scores. Usually the time duration, what we have observed for this cough molecule is approximately 5 days. It takes around 5 days that it produces significantly better results as compared to other cough suppressants. Okay. The quality of life improves, the severity of cough reduces, the amount of bronchospasm they are undergoing, they reduce it, because cough itself is a bronchospasm. Cough itself causes bronchospasm. The more the patient coughs, it's like a vicious cycle. Bronchospasm will predispose cough, and the more cough is undergoing, more bronchospasm is predisposed. So although it's not a bronchodilator, still it reduces the amount of bronchospasm, and it reduces the amount of muscular cramps the patient is having. Okay, so it's a very, very good molecule. So this is the same thing. They have compared the results of levocloresatine versus propizine and other molecules like codeine, cloresatine. They have compared, and see, they are comparing it at day 5. That's what I said, that day 5 is usually when we get the best treatment results. Okay, it's just the data. All right, we'll move further. Other molecules they would have also seen, like C 0.12. So conclusion, in conclusion, I would again like to tell you all that chronic cough is a very common entity which we see in our day-to-day clinical practice. With the right kind of approach, with the right kind of stepwise approach, right kind of history taking and clinical examination, and having all the diagnosis of chronic cough in mind, one can easily come to a diagnosis and can easily help them get relief from it. And the two molecules which we have paid special importance today is benzontate for chronic non-resolving cough. Can be used in the doses of 100 mg TID, or what I prefer using is 600 mg on a daily basis. That is 100 mg, 2 tablets or 2 capsules on a daily basis. Then levocloresatine as a cough syrup molecule. Okay, so but even prior to using these agents, it's very, very imperative, it's very, very important to come to a definitive conclusion of your diagnosis. All the diagnosis, all the history which we have learned today, all the diagnostic things which we have learned today needs to be kept in mind. And that is when your workup would be extremely, extremely complete, and your patient will be thoroughly benefited. Okay, so thank you so much. This is all from my side for today. And now I'll be stopping the screen sharing, and I'll let the house open for any further questions if anyone has. I'll be more than happy to answer.
Sir, there are no questions in the chat box.